Court, and we have a few announcements and lots to do. A wonderful talk for you today. So welcome everybody. Hello. I can't say good morning or afternoon because we have people joining us from all across the country as well as other countries. So we're so glad you were able to join us. Welcome everybody to the Penn State College of Medicine Navigating Primary Immunodeficiency Community Health Partner Echo Series. We're delighted to bring you this very important series with our partners at the Immune Deficiency Foundation. My name is Melissa, and I'm an education specialist with the Project Echo team. Before I get to some announcements that we have for you, let me ask my Echo partner to introduce herself. Jessie?
Hi, everyone. I'm Jessie. I'm an education program coordinator with Project Echo at Penn State, and I'll be helping out with the attendance today.
She does a tremendous job. Thank you so much, Jessie. And our project manager is also here. Laura, do you want to unmute and introduce yourself?
Hi, everyone. I hope you can hear me. I'm having so many technical issues today, but thank you all so much for joining us. We're really excited to be able to offer this program to you all. So thank you.
Thanks very much. Yes, we're all in the office today and we're used to working remotely. So we've all got just one tiny screen, but we'll do our best. I'm going to move on to just a few announcements that we have for you, but they are important ones. We do ask that you do not share the Zoom link that you have with anyone, but instead, if you'd like to share the series, please have them contact me so that we can share the link for registration. That way, if people are registered, they'll be able to get all of the wonderful resources that we have in store for you throughout the series. We also ask that you stay muted unless you're speaking so that we can be sure to hear those who are speaking. Closed captioning is enabled if you would like to use that. That's the CC icon on your Zoom screen. We also ask that if you're able, please turn your video on for the entire session. This really helps put names and faces together, but also we love to see your smiling face if you're comfortable doing that. Please do remember that no protected health information is allowed when discussing your experiences with patients or clients or students. We are recording these sessions and they will be made available to you, as well as all the materials that we use in the session. To get the recording, you just need to respond to the email that I will send you tomorrow, which will have all of the recommendations that we'll go over and all of the resources. You can just respond to that to say, maybe you missed a part of it and you'd like the recording. Please also respect the fact that we cannot give out any personal medical advice during the session, whether it be for you or a patient or client. So that's got to be a hard and fast rule, and I'm sure you understand why. Our partners at the Immunodeficiency Foundation have extensive and excellent resources and information on their website. So that link to the foundation will be included as well in all of the follow-up emails that I send you after each session. It's a wonderful site. If you're not familiar with it, I highly recommend you take a look. In the spirit of ECHO's all teach, all learn education model, we will all be on a first name only basis during the sessions. But most importantly, what that means is that everyone is here to learn, participants and expert panelists alike. And finally, we're going to do something a little bit different for this series. I'm going to ask you all not to use the chat for questions or comments. And that's simply because we have such a wonderful, large group. It gets very distracting. We often have people say, oh, I missed things in the chat because I was listening, or I couldn't listen to the discussion because I was watching the chat. So we're going to try just simply asking you to either unmute for your questions or comments or use the raise hand icon, and we will get to everybody we possibly can. If you do have a question that hasn't been answered, you're welcome to email me after the session and I will forward that to our panelists. But we have 6 sessions in the series, so we hope to get to you all at some point. Let's see, if you're logged in, however, with a phone number or something else we can't identify, please direct email Jessie if you can, or put that in the chats for our attendance records so we know who's here. Today, we were going to begin with our flash talk on navigating health systems. This is a huge topic, as you know, and we have wonderful Dr. Beth Younger here. However, we gave her this challenge. Echo flash talks are only 15 to 20 minutes long. Can you imagine trying to explain navigating health systems in 15 to 20 minutes? So what we did was ask her to offer the 3 or 4 key takeaways that she wants you to learn from this session. We will send you her entire flash talk, but pay attention when Beth talks because she's distilled this down to the most basic takeaways. Following that, we're going to have a sample experience that will be presented to you by Colleen. And this is just a kind of a sample of what I'm going to be asking one of you to send in for each session. We hope you'll be willing to participate in our collaborative discussion, sharing your own patient or client challenges and experiences as they relate to the shared experience. I'm going to be facilitating the series for us. And since we have so many people, we'll just simply ask our panelists to introduce themselves. Let's begin with Ken. Ken, can you introduce yourself just briefly?
Good morning from Texas. I'm Ken Bass, and I am a patient with common variable immunodeficiency. I also work with the Immune Deficiency Foundation as a Get Connected support group leader here in Texas.
Thank you so much, Ken. Diana.
Hi, everyone. My name is Diana, and I am the parent of a child with PI.
Thank you very much. And Colleen.
Hello, I am Colleen Brock. I am the manager of medical programs at IDF. I am a registered nurse. I am a patient with PI, and I have 2 young adult children with PI. So I live in all realms of it.
She's got the full range of experience.
Sure.
And Beth, thank you so much for your talk. Would you just introduce yourselves for everybody?
Sure, I'm talking to you from vacation in South Carolina, but when I'm not on vacation, I hang out at Johns Hopkins in Baltimore, Maryland, where I have well over 550 patients with primary immunodeficiencies for whom I care. So while I don't have the immediate experience that others do of being a patient or being a parent, I am a caregiver and feel very strongly about supporting this population.
Absolutely. Thank you so much.
Talk really fast because I've never done anything in 15 minutes. So
I told you, we make this a challenge. Since this is our first session, before we get to Beth's flash talk, I'm going to briefly share my screen and just talk to you a little bit about what the ECHO model is so you'll know what to expect. Let me go ahead and share my screen. Okay. Jesse, give me a thumbs up if you can see the screen. Okay. It's harder with only one laptop. All right. So first, what is ECHO? ECHO stands for Extension for Community Health Outcomes, and these are not typical webinars where you sit passively and have somebody lecture at you. The ECHO model focuses on active learning. However, with such a large group, we realize that only a small number of people might be able to participate in any one session. However, we do ask you to be engaged in the discussion and to participate, sharing your own experiences, because real world lived experiences and challenges are really what this is about. We learn from one another. Okay, let me move on to our next slide. Whoops. You'll hear me refer to our expert panelists as our hub team, and that is because the ECHO model is a model that uses the hub of a wheel. If you picture a wheel, the hub of the wheel, it represents our expert panelists, and the spokes are you, our participants, and learning goes both ways. Our panelists want to hear what your particular challenges are in your field of work. I know we have a lot of community health workers with us, a lot of school nurses, other types of nurses. And so your challenges may be very different than someone else's. And that's what ECHO is all about, sharing those and then collaborating together as a group to offer suggestions and recommendations so that we can help all patients who suffer from a primary immunodeficiency disease. Okay, the 15-minute flash talk, as Beth told you, is extremely fast. It's really not the focus of each session. The focus is on our collaborative discussion, and so we ask our experts to share 3 or 4 key takeaways in 15 to 20 minutes. It's really kind of the icing on the cake, but we do send you the flash talk so you can look at it a little more thoroughly at another time, and I will be sending this to you. Our collaborative discussion, as I mentioned, is really the heart of each session. Effective problem solving is collaborative in nature, particularly when helping those with primary immunodeficiency to find the best care and resources for them. These experiences will come from our participants, and I'll reach out to individuals in the group for each session. All right, the anatomy of a session. So real quickly, this is what each session will look like. We'll begin with announcements as we did today and some introductions. And then we will move on to our flash talk, which will be given by an expert speaker on several different topics. I'll be sending that schedule out to you with the follow-up email after our session. And then we go to a shared experience, which will be one of our participants sharing something that they've gone through related to the topic. And then we'll have our collaborative discussion. At the end, we will have a wrap up. And then the next day, you will get not only the flash talk, but also all of the recommendations. They will be compiled and vetted by our friends at the IDF Foundation. So everything will be available to you online. There is an online participant resource folder that you'll all have the link to, so you can look at past lectures, experiences, and all of the resources that we mentioned during any session. So here's what we ask from you. We ask you to please try to attend the majority of sessions in the series. Come to the session ready to be active and engaged learners. Think about the experiences and challenges that might make for a good discussion when I reach out to you. We also ask that you please, once again, respect the fact that no personal medical advice can be given about or to a particular patient during our sessions. Finally, we ask you to take a little bit of time to fill out the session evaluations that you will be sent so that we can be sure this series is meeting your needs. Okay, let me stop sharing my screen and we'll ask Beth to share her screen and we'll get into the flash talk. Beth, whenever you're ready.
I am sharing my screen and
okay, I don't see it.
I don't.
There. Sometimes
No,
it's a little bit of a
Zoom
delay.
link.
It's coming.
I don't. My talk isn't coming up. I think that you're going to have to do it.
Okay, sure. Do you want to just stop sharing and I'll be happy to share
Yeah.
mine? I'm sorry about that.
It's okay.
You'll have to just tell me when you want me to.
It still says I'm screen sharing, and
Yeah.
I'm actually not zooming anymore. I'm
Okay,
sorry.
I think I can stop the screen share. No problem. Let me go ahead and go back to sharing my screen. All right, you share your expertise. I'm fine sharing the screen.
Okay, fine. So here you go, 15 minutes or less. So basically, this model absolutely works for me because I always tell patients that I don't give them orders. I don't write orders. It's all about a partnership and a collaborative endeavor. You tell me what you want from me. I'll tell you what I'm hoping to get from you. And I think that that's the model that works for people who have chronic illness. And there are absolutely challenges that people who have chronic illness deal with, and whether they have a baseline health status that is less than acceptable, they can't do the things that they'd like to do. They have problems in this day and age with care teams that are so specialized that there's, at Johns Hopkins, we laugh that, there's people who are experts in the right big toe. So if you have a problem with your left big toe, you have to have a different provider. And that sounds a little facetious, but it truly is the reality in today's world. And you may have a care team in one place, but they may be in different locations. And it leads to good things because you can always usually get the latest, greatest advice, but it also can lead to fragmentation, miscommunication. One provider may not realize what another provider is doing. Nothing makes me crazier than for me to write a prescription and have somebody discontinue the prescription and not bother to tell me or change the prescription. And I think that's really difficult for patients to handle. The chronically ill also have a disproportionate need for healthcare resources. They're in this day and age, with the explosion of biologic therapies. There are new therapies, there are expensive therapies, and the chronically ill may also need accommodations to do the things that they can do. Go ahead. Next slide, please. All right, so let's talk about that less than optimal health status. Go ahead. So basically, the first question that's asked is, what is the baseline health status? Does it let the patient do the things that he or she wants to do? Does it let them engage in the activities they want to engage in, the job that they want to have, or are there limitations on things? Very, very important question to ask. What does the patient want to be doing? And how can we as healthcare providers facilitate that? Go ahead, please. What accommodations are needed? Does someone need a workaround? Some special arrangement so that things can happen the way they're supposed to happen? Go ahead. Moving to the next point, as I said, care teams. Who's on the care team? The second most important question is not who's on the care team, but who needs to be on the care team. Does everybody need a care team of physicians and nurse practitioners, or ancillary therapists, or social workers? Who's on the team and who needs to be on the team? Which leads to the question of what are the patient needs and how is the best way to meet those needs? Go ahead, Melissa. Which is what I just led into. And importantly, when you've got this team, is there a gatekeeper, and does there need to be a gatekeeper? My personal prejudice is that there does need to be a gatekeeper. There needs to be someone who can handle all of the dangling strings and tie them into a nice, neat bow, as opposed to a Gordian knot. So I believe in gatekeepers, and I think patients benefit from gatekeepers, but that model might not work for everyone. Go ahead. And importantly, how does the care team communicate? It's actually not funny, haha, but funny, because I'm really not a very political person. But I heard that at the Republican presidential candidate debate last week, someone raised the issue of healthcare systems and electronic patient records. And supposedly one of the hallmarks of Obamacare was that there was going to be a single electronic record across the country. And people invested literally trillions of dollars putting particular electronic patient records into place, but they don't all talk to each other.
That's right.
Electronic patient records with the same name at Johns Hopkins don't talk to those records with the same name in Philadelphia or in California. So people are under the illusion or delusion that a particular record is available to everyone. And because I have this record in one place, that anybody can open up the records in another place. It's just not the reality. And as I said, it's almost a delusion for patients. They thought, well, all the records are right there. Why couldn't you open them? Well, I can't open them, and I don't always know what's going on. So that communication link, I think, is one of the most important things in helping chronically ill people get into the system and benefit from the system. A really important thing to consider. Go ahead, please. And then bottom line is, do they communicate? And sometimes the answer is not very well or not at all. Again, problematic for people who are counting on assistance in managing an illness. Go ahead, please. Talking about high therapies, what are the therapies? Are those therapies the only options? As my son calls them, the Jeopardy drugs, all the drugs that are advertised during while Jeopardy is on, the monoclonal antibody therapies, the other therapies that have 9 syllables in the name, who do different things. And there are multiple drugs which can do things, and sometimes you need to add them together, sometimes you need to take them apart. but what are the therapies that will benefit a particular patient? Go ahead, please.
Do you mind, Beth? I see a hand up. Do you want people to
Sure.
wait till the end, or would you rather?
No, I know, no, but
Okay.
you can't take this out of my 15 minutes.
Nope, promise. Rita, go ahead and unmute and ask your question. Thank you. Rita, did you have your hand up? Rita. I see a hand up.
I do too.
There we are. She's coming.
Okay, can you hear me?
Yes.
Yes, we
Okay.
can.
So I think it's just a comment about the communication part. One of the things that patients need to keep in mind is just because we are all part of the same health system, so whether it's Johns Hopkins or CHOP or somewhere, I'm not familiar with anything that's not in the Northeast, but
Welcome to my world.
we don't always communicate across our health, our own system. So, you know, we're the immunology clinic. We don't always have great communication with cardiology or great communication with neurology. So just because we're all part of the same health system, please do not assume that the doctors are talking. Make
And
sure
then
that you're
that's-
asking them, hey, can you send a message to my immunologist, or can you send a message to my cardiologist?
And that's extraordinarily problematic and frustrating for patients. At Johns Hopkins, we have multiple campuses within Baltimore. We have an East Baltimore campus, and we have what's called the Bayview campus. Well, there's an immunology department on both of those campuses, and patients don't understand that they're talking to me in East Baltimore, and I'm not talking to the people at Bayview. And we don't, even though we all practice immunology, we tend not to practice it exactly the same way. And it's extraordinarily frustrating for patients. And I'll tell you, it's extraordinarily frustrating for other people in the system who make referrals. Well, I referred him to immunology. Well, you didn't refer him to me. You referred him to immunology east of East Baltimore. So it's very frustrating for patients. And it's one of those things that we have to be cognizant of, and I think probably deal with a little bit better.
Thank
Go
you,
ahead,
Rita.
Melissa.
That was a great point.
Thank you. Go ahead, Melissa, my next flash. So, and then there's the whole question of those therapies. Is pre-authorization to get those therapies necessary? The question is, who does the pre-authorization? Do patients have responsibility for pre-authorizations? And if so, what is their responsibility? The joke that I have is I have a huge picture on one of the walls in my office, and I laugh that it covers the hole where I bang my head a couple of times a week as I'm trying to deal with an insurance company getting a pre-authorization for a drug that my patient absolutely positively has to have, for which there's no alternative. And as I said, I keep having to buy a bigger and bigger picture as the hole in my office wall gets bigger and bigger. Go ahead, Melissa. And then the question is, when you prescribe these therapies, can the patient or whomever is helping provide that care manage the therapy? I can write an order and a prescription for anything, but if it's something the patient can't manage, what's the point? And it goes back to those 6 slides ago about communication and what people want, and establishing that partnership that has to work if chronically ill people are going to be appropriately cared for. Go ahead. And then the question is, what if the patient can't afford it? And that's something that we stumble with all of the time. I have patients, about 2/3 of patients with primary immunodeficiency have what's called an antibody disorder. We laughingly say we can't fix the engine, but if we keep gas in the tank, we can keep the engine going. And that's the therapy that I provide to about 2/3 of my patients, is gasoline in the form of immunoglobulin. Immunoglobulin is probably about $100,000 a year, give or take, depending on what the dose is. Insurances do cover it. Medicare covers it at 80%. If a patient doesn't have a Medigap policy to pick up the other 20%, they can't afford this therapy. No one can afford this therapy. I don't care how much of a millionaire you are. Nobody can afford that kind of money and pay their rent and buy peanut butter and jelly and macaroni and cheese if that's all they can afford. So it's a huge question, and it's a question that we have to deal with constantly, and patients do as well. I have several patients that I cannot put on therapy because I can't bankrupt them. It's a question of, do I give them therapy or do I keep a roof over their head? It's a hard question to answer and very hard for patients to deal with. Go ahead, please. And then that last bullet point, needs for accommodation and what accommodations are indicated. Is it something as in your face as somebody needs a wheelchair or an oxygen tank, or we just came out, or so I've heard, of the COVID pandemic? You know, what was necessary for patients who have a greater propensity for getting infections in a world where infection was rampant. And I wrote letters by the dozens to employers that said, these are the things that my patients need. I sent letters to colleges. You know, my college kids love me because I can get them a single room by snapping my fingers. What's necessary and what's needed, and how do we get those things? Go ahead, please. And who's in charge of making sure they're supplied? So there's legislation. There's the American with Disabilities Act, and we can quote that act chapter and verse and make sure that patients have what we think they need and what they think they need. But there's lots of people out there who think that maybe what we think is a little over the top and don't want to supply what we believe is needed. So that can be a stumbling block as well. Go ahead. So bottom line, and my take-home point, as I was told, and I'm very close to my 15 minutes, my take-home point is the delineation of responsibilities. As I said, my whole philosophy of care is partnership. I do not enable patients in any way, shape, or form. I make it inherent that they have some responsibility for their care, for their needs, and I certainly will assist them, and I will go to the nth degree, but they have to have some responsibility for themselves, whether it's they or whether they're a caregiver. They have to advocate for themselves. They have to say, this is what I need. I can't function without X or Y, so please help me to get X or Y. They need to do what they've agreed to do. If I prescribe something that costs $100,000 a year for it, and I get a prior authorization for it, and I help you get it paid for, and you actually, some people have no financial responsibility at all because there's copay assistance programs in addition to insurance programs, but I need those people to agree to do what I think they're doing, and that's their responsibility. They also have a huge responsibility for communication, and that's telling us about changes, telling about things that are stumbling blocks that are in their way. They have to communicate because I can't read their minds and I can't know what's going on in their heads unless they tell me about it. As healthcare providers, our responsibility is to make sure that we don't enable patients, but we assist patients. We need to help them understand therapy, what the rationale for the therapy is, that this is what we're doing, but we're doing it in partnership with them. And then the third group of people are the ancillary care people. They need to do the tasks that are necessary for them to be doing. So this whole responsibility, everybody's got a piece of the proverbial pie, and everybody has to put their piece together so that they all work. I have plenty of patients who would love me to run their lives for them and want me to do everything. I can't do that for the hundreds of patients that I have, and I have to count on them to be responsible for the things that they can bear responsibility for. And I think that's my last slide, Melissa, is it not? Yes. And then who's responsible for addressing these challenges and who should be responsible, which goes back to the points I was just making, is that everybody needs to understand what their particular responsibilities are and feel prepared to meet them with some assistance if necessary, independently if necessary, without enabling. And that's my 15 minutes, and I came in under budget.
Thank you so much, Beth. I'm sorry. I feel like maybe I was a little too harsh on the 15 to 20 minutes. Oh my gosh, Colleen.
No, it's a joke because I'm a native New Yorker and I get into the mode and I talk faster and faster and faster and faster. And everybody always says, back it down, Beth. And I was like, how much do I have to back it down? And it makes me a little crazy, but
hey, that's okay. Maybe we have to always get New Yorkers for flash talks. They're trained. Let's move. No, thank you very much. And the resources you all see will be all sent to you. So don't worry about that at all. Before we move on though to our shared experience, I want to ask if anybody else has questions for Beth. That was a wonderful talk. Lots of great information.
can't have been that good, guys. You have to have questions.
I was going to say, you must have been so thorough. You covered it all.
I beat them all up and told them they're responsible for themselves. That could be it. Now they're all cursing me.
No, please feel free to unmute. I know we've got people from all different walks of life, lots of wonderful different professions that we need to hear from so we can all learn from you. So anything you want to ask Beth, go right ahead. Raise your hand, unmute. We're all very informal here, informal and friendly. All right, I'm looking for hands.
I have a question.
Go for it.
Yes, you had mentioned gatekeepers on care teams, and I imagine depending on the care team that could be a nurse, could be one of the physicians of the care teams. What are some examples of people that are the gatekeepers, so to speak, on your care teams?
So for us, we're very protective of our patients.
Yeah.
We take what we really think is good care of them, and we really do try to meet all their needs. So my partner and I are more or less joined at the hip after 20 years of a professional partnership. We're at the point where we finish each other's sentences. So that the two of us absolutely manage things. And as I said, one of my pet peeves is if I write a prescription for something and somebody decides, well, the patient doesn't really need it and discontinues my prescription without calling me up and saying, Dr. Younger, why, what, and what are you thinking? And la, la, la. And I may agree after that conversation that discontinuing is okay, but don't discontinue something I prescribed. So that kind of thing, that's what one of our gatekeeper jobs that we absolutely do. And we tend to be, once we diagnose a primary immunodeficiency and start the appropriate therapy, sometimes we back it off a little bit. Patients may have other issues. And for example, may have a lung disease, and the lung people are more important once we get our therapy in place than we are. And that's kind of one of our end goals, is to try to make the immunodeficiency not the foremost things in people's lives so that they can address other things. So there are nurse practitioners who do the gatekeeping. Some insurance companies think it's their job to gatekeep. But basically it's someone who's working well, who's communicating well, on whom the patient knows they can depend or rely. I'm crazy about communicating for my patients, and they know when they send me an email, if I don't respond to their email, they know they've typed my address wrong. So I have a very funny email. My last name is Younger, but there's no R in my email. And if you put an R in it, it doesn't kick back to you, but it doesn't get to me. So if people write an email, they know that they must have typed the address wrong and put an R in it, because I'm crazy about responding to their emails and making sure that they're getting the communication that they need. So there's a variety of people that fill that role, but I think it's imperative to have someone fill that role.
Great, thank you. It's a very good answer.
Yeah, thank you for that question. I see we have one question in the chat thank you for holding off until we get this one answered. So Megan writes, Beth, from a patient perspective, I have asked one specific member of my care team to be my team captain or gatekeeper within my complex care team. So just a comment from Megan there.
Exactly. And that you're exactly the kind of patient I want to take care of. So come on down to Baltimore.
All right. Well, I see Colleen has a hand up. Go ahead, Colleen.
I have a question, Beth. As far as being part of the care team, how do you see a school nurse, whether that is pre-college or college nurse, participating in being a care team member for a person with PI?
So I think that role is really important. The unfortunate thing is that in 50 states, school nursing is different in every single state. And there are still states where one nurse may cover 7 schools, or the secretary might be the quote unquote school nurse because there is no registered nurse in the school. So it's a very different answer literally all over the country. When I send my kids to college, I send them with a cover letter and I fill out their student health forms and I talk to them about, okay, how much do you want me to share with the student health at the particular university you're going to? And I write, if they want me to say, no, tell them everything. And I write a very complete letter that this is what my patient has, this is what I'm treating them for. These could be the ramifications of their illness. And I still get at 2:30 in the morning calls from student health. Well, your patient here has mononucleosis. No, they really don't. You've measured their antibodies to the monovirus and you've picked up the antibodies that they're getting from their gamma globulin. Trust me, they don't have mono, but thank you for catching it. But I do things like that, and I am available to both primary schooling, high schooling, and college. And I'm all about educating. The IDF, while we're blowing the horn, Colleen, has an excellent publication on the role of people in schooling and how to work your child through that maze sometimes. But it's hard to have a single answer, as I said, because school nursing is different in 50 states and every little town in each of those 50 states.
Absolutely. That's a great question. I know we have a lot of school nurses in our participant group, so we're hoping to hear from you all. If there are no more questions, I'm going to go ahead and move on to our experience. We have a sample to show you today that Colleen has provided for us. I just want to repeat that I'm asking everybody to not use the chat unless nobody is able to or wants to unmute, just so we can keep track. I don't want to miss anybody. So if somebody does put a question into the chat, please hold off if you see it so I can be sure I get to that one. Once I share my screen, Colleen will read the details of the experience. I sent it out to everybody yesterday morning, so you should have it. Hopefully you were able to take a minute and just look it over. And then what I'll do is we go to participants first, always with Echo. And so I'll ask you all what questions you would have. If this person came into your clinic or your school, or you were working with this person, what more information would you like to know before you start suggesting next steps? So we'll ask participants that, and then we'll ask our hub team, our experts, what questions they might have. And then we'll go back to participants for suggestions. That's where we kind of all work together to collaborate on what some next steps might be for this person. And then we'll finish with our experts giving their opinions for you. Okay, so we'll get more and more used to that model as we go on, but I just wanted to give you just a brief description. I'll share my screen for you, Colleen, and then you can go ahead whenever you're ready and start with the challenge.
So I kind of have combined 2 situations here that we get a lot of comments and questions through Ask IDF. So this is a 54-year-old woman who is married with 4 children. She has common variable immunodeficiency and was diagnosed at the age of 49. She receives IVIG every 3 weeks. She also has rheumatoid arthritis, hypothyroidism, and is a 10-year breast cancer survivor. So she's had some issues. She has several specialists, a PCP, an immunologist, an endocrinologist, a rheumatologist, and an oncologist. So she's got quite the team of people that are overseeing her care. Next slide. Now, the problem is she's moving from Charlotte, North Carolina to Columbus, Ohio in 2 months. She has located new specialists to take over her care, so she's done her homework, but they're not all within the same hospital systems. She is very stressed about having to switch to new specialists, leaving the ones who she has seen for quite a while, and going to a new home healthcare provider for her IVIG, and all of these because they have different health record systems. Next. So she's got a lot of questions about her move. How is the best way to handle the move? How does she handle the transfer of her records? What if all of her records are not electronics? Obviously, she's had radiology tests done, and one of her doctors actually still does paper records. How does she get her new specialist to coordinate her care since they have different record systems? And in the end, how do we help to ease her concerns? How can we make this move a little bit easier and a lot less stressful? So there's sort of two scenarios going on in this situation. You have somebody with PI who is moving, they are changing states, and you have somebody who is dealing with different healthcare systems. So what would you recommend to, again, create less stress for her and to make that move more simple and simplified?
Okay, so before we get to recommendations, I'm just going to ask if anybody has any questions that you'd like to ask, just some to get more information about this person that might help you to make recommendations. And the person who presents the experience may or may not have all the answers. You know, we all know you only have so much time to spend with clients or patients or students. So you can always say, I just don't have that information. But is there anything you'd like to ask Colleen about this person that might give you information you'd like to know? John, go ahead.
I'd want to know more about, is this a family move? Is it a part of a larger planned move? Is this an unexpected, really disruptive move in other ways besides the medical? Because all of that is going to play into what they will be able to deal with. And I'd want to get a sense of what their confidence is about what they've planned so far. You know, are they, do they say it's all in place, but I'm in a panic, or is it all in place and I'm having some assurances? I think those are things I'd want to know.
Yes, excellent questions, John. Thank you. Colleen, do you want to try and answer some of those? Would you have that information?
It is a planned move because she has had time to research which doctors she wants to transfer her care to, but there's a lot of uncertainty with going from, as Beth said, a gatekeeper and somebody who is in charge of all her care, to now who does she pick to be that team leader, and are they all going to talk to each other? How does she get them all to talk to each other? And it is a family move. The whole family is moving together.
Thank you. Okay. Any other questions from participants? Go ahead, Janie. Unmute and correct me so I know.
There we go. Hi, it's Janny.
Janie.
So, does this lady currently have a primary care physician? And in her move, how close is she going to be to Ohio State? And what is her insurance?
That I don't know, unfortunately.
Okay. Good questions, though. That would be excellent information to know. Yeah, if you get to see this person again, that's wonderful. Any other participants? Can I see you? I'm going to get to the panelists for sure. Monica, did you have a question?
Yes, I do. I would like to know what, besides the research that she has done so far for her health care, for medical care, what about the support system? do, she's gonna have family support, somebody who will help her during that time, with family, because there is times when you move to another state, you don't have family around. So what is gonna be her support system?
Great questions.
It is a good question. And in talking to them, it is going to be immediate family in the beginning. And then hopefully they are planning to find a church family and kind of go from there. But in the beginning, it will only be immediate family. There is no extensive family. They live in other states.
Yeah, that's great to know. Go ahead, Laurel.
Hi. So my question is she tech savvy, using the phone and apps in the phone and ability to navigate within an electronic system?
Good question.
She said she was fair. She understands most of it, but her children are better and willing to help.
Yeah, great question.
Mm-hmm.
All right, Ken, go ahead.
Yeah, kind of jumping off of what John had mentioned earlier about insurance. Does she know what her insurance will be? Because that's the challenge, to know which doctors I can use, who's in my group, and doctors won't sign you up until you've got insurance and stuff. So it sounds like if the whole family's moving, maybe they'll get to keep insurance they've got or something. But that'd be a big question to help her guide into which doctors to use.
It is her husband being transferred, so their insurance will stay the same.
Good.
It's just a different state.
Great question. I'm just looking at time, so I'm going to move because we have so much expertise on both the participant and panelists. I want to make sure we get to recommendations. So if you have other questions, participants, feel free to ask them, but let's move on to some recommendations from participants. What would your next steps for this person be? What would you be able to suggest to her? Go ahead, Laurel.
Hi, this is actually kind of almost my exact scenario in a sense where when I moved to Chicago, I have 3 health systems that I navigate through, and even at the NIH, and of course they all don't use the same platform. So what I have learned to do is I have to be the one that's shifting all the information, and I downloaded an app called TurboScan where I can use my phone. And when I have a report that comes in from my doctor, or I can get it off of, let's say, Northwestern system, I print it, I scan it, I keep it in my phone. So I have a detailed record within my phone. And then I'm able to email that to one of a doctor's office directly, or if it's from another doctor's, I can add it into Northwestern system. And I take the responsibility of just sending them those records in advance, just to make sure that everybody has what they need. Then, because I have it all in my phone, then when I'm at an appointment, of course, because things happen, they don't get the report, they don't see the report, somebody didn't upload it, whatever, in the context of my next appointment, I then am able to say, oh, well, we don't have the results of your last labs. And then I can say, well, here they are. And as I'm going to an appointment, I always come to my appointment with my last labs that I had, or anything that I think, any document that I think that they may not have seen. So you have to I feel it's significant for you to have your own medical records, in a sense. You don't need to drag this big volume with you everywhere you go, but unless it's the first ones, but just to make sure that you have it in a little folder so that you can just hand it over to them so they can make the decisions, because otherwise you can't move forward if they don't know what just happened in the last 6 months.
That's a great suggestion. Thank you, Laurel.
Mm-hmm.
Okay, Laura's iPad is what I see. So Laura, go ahead.
Hi, I'm Laura. I come to this as a physician in radiology and also a parent of a young adult with PI. And my specific comment in relation to health records is, when it comes to radiology, a picture's worth 1,000 words to us. We don't want the report, we want the images. And so one of the best things that she could do is get a CD, or however they choose to package their images, and keep it with her. She can take it from system to system. If she's in multiple systems, she can allow them at each system to download it into their individual packs so that she exists in radiology form for any future tests. But then she should always say, I require that back once you've uploaded it, so that she is in direct control of all of her images, because otherwise they will repeat studies that don't need to be repeated.
That's a fantastic point. Yeah. Thank you for that. Anybody else?
Susan?
I'm not able to, I don't see the raise my hand on mine.
That's
so
okay. Unmuting is fine.
Okay. I will, this might be piggybacking a little bit, but it is also a little different than the speaker 2 people ago. I'm so sorry. Yes, having a electronic in the app and everything is wonderful. I would also do both. I would have a paper. I have a binder. It is intimidating to some doctors. I understand that when I walk in, but I have a binder with, I always ask for notes to be printed out, or if I do not receive notes from that doctor, that I will bring either a note taker or I will take notes myself. I have all of the scans. I mean, anything and everything in my medical history, I have in a printed binder, because they have only so much time with me. And if I need to pull out a piece of paper and hand it to them and say, no, this is what my immunologist says, if I'm seeing another specialist, or this is the medicine I'm on. I also have it for my 2 sons who both have CVID as well. The other thing is I have a 1-pager. I call it a medical 1-pager. It's printed on its front and back. It's printed on colored paper. I hand it to every doctor that I go to. It explains what a PI is, what CVID is very briefly. And then all my doctors, all their numbers, all my medications, all my previous surgeries, all that. It sounds like a lot, but it does fit on the page, any allergies or anything like that. That's a little less intimidating. But I know my new primary care was like, oh my gosh, where's the binder? I mean, we were making a joke about it. She's like, it was a little intimidating. And I said, I know it is, but I have to be in charge. Even though I do have a gatekeeper, my immunologist, I'm lucky. I have to have everything together, especially if I'm seeing somebody new. It could just be a skin cancer thing or something, but it all has to be documented, paper form. And I do electronic form as well, as much as I can get electronic form.
Great. That's a great suggestion, Susan. Thank you. And Beth was talking about being your own advocate. So that's wonderful. I see another hand. Susan, another Susan. Go ahead. Susan, you're muted. That's okay. It happens every session and to me all the time.
I'm in an unusual location. Thank you. I made a major move from the U.S. from Canada to the U.S. In order to get better care for immune deficiency, and I also and so that's kind of led me to doing mentoring for people here in Canada, because I did connect with Immune Deficiency Foundation, and the 2 things that I found the most helpful when I made this big move to some place where I didn't know anybody or anything, and it was an entirely different health system, was finding a really good primary care physician who was my hub. We would sit down and prioritize, okay, first you got to get this surgery done before we can go to the next step. So he was really good at helping me to stay on track and prioritize. But then I would find my own specialist, but he would keep track. That was super important. And the other was that I had a mentor from the Immune Deficiency Foundation, a volunteer, and he would pick me up. I had a charity flying me to some of my appointments, and he would pick me up at the airport, and then we'd have coffee or lunch, and he would help me learn how to keep a binder, like Susan was just saying, and just things like that. And I became so comfortable with this situation that that I have my binder and I have my way of meeting new doctors. I have my way of keeping track of what needs to be done next and what I've already done. And so
Right.
those two things, having the primary care physician who's like an information hub, and then having a mentor locally to help me get oriented, were the
Yeah.
two most important things.
Absolutely. Yeah, thank you so much. And I put the IDS website. I know I said I'm going to be sending it to you, but you get a head start. I'm just looking at time. Everyone's given such wonderful questions and suggestions, but I want to give our panelists a chance to share their own. So panelists, what would your suggestions be?
I think I'll start because I'm at the top on the screen here. Bottom line is that people had different suggestions, and that's the key, is that not the same thing works for everyone. I will tell you, I just had a patient refer to me, and she's had a problem with elevated white blood cell counts for a very long time. This lady sent to me, as heaven is my witness, 900 pages of CBCs, which is the lab report of a blood count. I think she expected me to look at those 900 blood counts. I have to tell you, I didn't. And when I was printing them out, I didn't realize there was 900 pages of them. And in cases like that, I think you have to synthesize. So yes, keeping that binder sounds extraordinary, but I would never read that. I would read the immune part of it, any ramifications of your immune part. The problem with people with this particular illness, primary immunodeficiency, the key piece is how is it diagnosed? So the initial lab work, whether that lab work is 25 years old, whether it's 35 years old, or whether it's from last week, is key. And one of the things we do in my clinic at Hopkins is we have a spreadsheet, and we give every one of our patients the spreadsheet that lists the lab work, the intervention we made, follow-up lab work, did we change an intervention, so that when our people move or go to someone else, they give them that piece of paper, because that piece of paper will help the new person care for them, provide care for them. It will also help them get a prior authorization from the insurance company for an expensive therapy. But I think the records and the folders that you all have are fabulous, but you need to think about synthesization. As I said, I didn't look at 900 CBCs, heaven forgive me. I got a hint after looking at 50 of them. Yes, this lady's had an elevated white count for a long time. This is what people have done to address what the etiology for it was. So I think the synthesis, I can't talk today, I'm sorry. Synthesis is important. And not every piece of paper is important to us as providers. Certainly it is to you all. And that you have a record of what's been done, when it's been done, and how you've responded to it. But the expectation that a new provider is going to look at that and go page by page may not be as realistic as you would hope it would be.
Thank you. Good perspective from each side. We have 1 minute left. Any panelists want to offer some quick suggestions?
I'll go ahead. I did have, while specific to the, case study, interview that new doctor. We just switched an immunologist for my son, and it was very important to actually, instead of, signing up with somebody who you think you'll mesh with, definitely meet them in person for that, insurance second opinion, and make sure that you're on a good level with them before you do make the switch. And then one other comment, going far, far back to what Colleen had said about the school nurse in the original flash talk. Part of getting my son diagnosed was, how many illnesses, everything like that. Something important for those school nurses is documentation. Any chance you get to document, not just sick, absent, went home, but you know, they had a fever, they had diarrhea, stomach bug, all that stuff. As a mother, I was bombarded with sickness every 3-4 times a week. I think he missed something like 90 days of school within his first year. It came down to I couldn't record it all. Those things are important, and for those school nurses to document those things. So when I pulled it up, you know, 3 years later, when I was like, hey, something really wasn't right, we were able to have that documentation before I started making the binder and the notepads.
Great. Thank you very much. I apologize. We didn't get to everybody, but we're past 12 o'clock. So we want to respect your time. We will send a summary that will include all recommendations. I saw Colleen writing everything down. They will all be vetted. Thank you so much to Beth for speaking, for your presentation today, which you will all get. Thank you all for joining us. Thank you to our IDF friends. Take care, everybody. Hope you have a wonderful rest of your day.
Thank you,
for the
everyone, and have a
opportunity.
great
Okay,
week.
thank you.